So I'm now going to introduce very briefly our speaker so I don't steal his time. I'm really pleased we have Dr. Srinivas Murthy, who's a professor in the Department of Pediatrics in Vancouver and BC Children's Hospital. He's both an infectious disease consultant and an intensive care physician, trained at the University of Toronto and the last few years here in Vancouver. And the reason we're so excited to hear his presentation tonight is that he's, despite his youth, he's become a leader in Canada in rapidly organized, randomized controlled trials to attempt to figure out how best to treat COVID-19 or how not to treat COVID-19. And on the basis partly of some of this work, he's recently, last month, been appointed to the chair in pandemic preparedness research in the University of British Columbia. So Dr. Srinivas Murthy, thank you very much for joining us, and take it away.
Thank you, Tom. Let me just share my screen here for a second. Does that work? Everyone sees my screen? Great. So I'm Srinivas Murthy at the University of British Columbia. I'm going to talk about treatments, specifically COVID-19, and specifically finding treatments that work. We'll have sort of an overarching approach to things, take a broad, sort of large-scale view, and then drill down on some details and some numbers as well. I put the figure of a swirling tornado there because I'm sure as many of you have been following in terms of the literature, in terms of the media, in terms of public pronouncements, things change quickly, and it's very difficult not to get caught up in a whirlwind, so to speak. I have some conflicts of interest to declare. As Dr. Perry mentioned, I have salary support from the Health Research Foundation of Innovative Medicine Canada as a chair in pandemic preparedness research. I also have intellectual conflicts of interest that I should probably declare. I work at the World Health Organization as the co-chair for clinical characterization and management for COVID-19. And so what that means is sort of I help write their guidelines and help sort of disseminate knowledge. As everyone knows, there's all sorts of different thoughts and opinions about things, and so hopefully these conflicts don't have any bearing on what we hear. So objectives, we'll provide an overview of what's currently available for patients with COVID-19, both in terms of the science that informs their availability, as well as the science that informs their use. And then we'll discuss ways that health systems can as part of a learning health system. So I think that's what we all want, especially as it relates to a pandemic. That's something that we can learn as much as possible, as quickly as possible. So the 10,000 feet view, we'll start there as to, why we are all at home most of the time and our kids aren't going to school and we are distancing all the time, is sort of these three avenues. What we want is a good way of preventing the disease, and so we all have our masks right now. Ideally, we would have some sort of treatment that would prevent us from getting disease, but that does not exist, and we'll talk briefly about that. And obviously the vaccine, which at some point in the next, hopefully, few months to a few years, will be rapidly and readily available. We want a better diagnostic system so that we can be more rapidly aware of current status as it relates to COVID-19. And obviously, we want treatments to minimize the burden of the disease, namely the severity, the morbidity, and ultimately the mortality of it. So all of the things that we're doing right now are effectively waiting for these things to be optimized. And so this is, as we say in sort of the clinical research world, this is sort of the biggest deployment of biomedical and clinical research in history, in that we're trying as quickly as possible to learn as much as possible to minimize the pandemic's impact on society. As it relates to treatment, we're sort of taking it at a variety of different stages. In a perfect world, we would have a treatment that was available at the time of diagnosis that would prevent you from progressing to requiring hospitalization. In a less perfect world, we would have treatments at the time of presenting to hospital with a confirmed case that would prevent you from becoming, say, severely or critically unwell. And then in a even less perfect world, we would have treatments that would prevent you from becoming, from having a mortal outcome or a lethal outcome once you become critically ill. So what we need, really, are treatments at every step of the way, and these treatments may be different depending on what we end up finding. So let's start from the beginning, I guess. So chapter 1, I'll break this down into sort of a chapter book, because I like to read. So who are the main players? And so if we go back in time, this is back in February, March, and it feels like, I'm sure everyone appreciates this, but it feels like this was 10 years ago at this point when we started to first hear about this from Wuhan in China. And we started to see the first papers. They were reported in the Lancet about what these patients were like, what their mortality rates were, and what the clinicians there in Wuhan were using. And these were sort of the main treatments that were available and were provided to patients at the time. So you see that most patients got antibiotics, some patients got antivirals, a lot of patients got steroids, IVIG was used reasonably frequently. And so these are sort of just the non-specific things that when you don't know what's happening with a patient in front of you with a newly emerging disease, with no science to back you up as to what could or what does not work, this is what sort of the clinicians fell on. Antibiotics, antivirals that they hoped would be effective against coronavirus, although they had no either biologic or clinical data to support that. Steroids, because like all of us, we all think steroids work when we don't know what else is going on. It's our go-to medication that sort of treats a lot of different conditions. And IVIG, or intravenous immunoglobulin, because we think antibodies must be good in a disease that we don't know what it is. Obviously, things have changed quite a bit since those first reports in China. And this is sort of a real-time tracker that the Financial Times puts out about, say, where the disease is and where it's going and the current case counts. And as you can see from sort of the initial surge in China, where there was hundreds and arguably close to 1,000 deaths, the average daily deaths now globally is upwards of 5,000 to 6,000. And while the U.S. was the epicenter for a period of time, that has shifted to India and the rest of Latin America, which is now seeing the largest clusters of disease. And that's important to recognize because health systems, as they respond to this, obviously treat patients in different ways. And a lot of it's dependent on capacity, and a lot of it's dependent on availability of treatment. And so in places in the world where some treatment may not be available, we may not be able to stem that large burden of mortality, those thousands and thousands of deaths that are happening every day right now. So I guess that main principle of making sure that something is accessible to the world is something that we really need to keep in mind as we sort of move forward over the next period of time. So as we think about research during outbreaks, and this is a classic figure that we always like to show in sort of the space of pandemic research. On the top is what happens currently. And as soon as an outbreak is sort of declared or is even hoped that it's declared, there's a public health response that sort of scales up surveillance, that sort of scales up testing and diagnostics and communication strategies. And then there's a preclinical research response, because disease is characterized, sequenced, what have you, treatments are developed, and then tested in a clinical research response, which typically is been at the tail end of any outbreak. And so if you look at the SARS outbreak in 2003, if you look at the 2009 H1N1, if you look at the 2014 Ebola outbreak, all of those had the clinical research response sort of at the tail end of the outbreak. And so we weren't able to learn during an outbreak or during a pandemic what could actually improve patient outcomes And so the hope is that we push that clinical research response leftward. And so it's integrated into the public health response and into the preclinical research response, sort of being able to scale up research in as sort of a rapid a time frame as possible, with the hope that those top peaks of mortality or top peaks of even case counts are pushed downwards, quote unquote, flattening the curve. And you can tell even from this current outbreak, where, say, we have more accessible testing and testing technology, for example, is scaled up, maybe we've reduced the burden of the disease in general purely by a biomedical research response. We wrote back in March, and this is way back when at the very beginning, as to what to do for a patient who's critically unwell with COVID-19. This is March 11th, so before we had any cases in Canada or the United States, and based on the data, that the care of these patients is the care of any patient, in that there was no specific treatment at the time. Basically, the care of COVID-19 is the same as the care of any patient with viral pneumonia, plus obvious risks of transmission that need to be incorporated into care pathways. It took us 8 months, or sort of 6 months, I guess, I have to do the math, to have a treatment. And this is the first treatment that the World Health Organization and most guideline bodies have sort of universally recommended for all patients of a certain population, namely patients who are hospitalized and are severely ill, requiring oxygen, a strong recommendation for systemic steroids. I think that time scale, namely, we knew nothing in March, and we know definitively in September what works. That's something to sort of be proud of as sort of a health system. It's rare in medicine that there's a question asked and then a question answered. And we'll talk sort of the process as to how that works. This is what we'll talk about. We'll talk about sort of the main players in coronavirus treatment: hydroxychloroquine, convalescent plasma, remdesivir, and steroids. How we got to where we are now with each of these, and what we could have done better in some ways. So back in January, people started to publish things on chloroquine. And chloroquine is an ancient drug that's been used for malaria, obviously, but for a variety of different other infectious and inflammatory diseases. And this was the sort of the main paper that came out in Cell Research, showing that in vitro, chloroquine seems to work against this new coronavirus. And this was rapidly performed biomedical work. As soon as the virus was isolated, chloroquine seemed to have plausible effects. And if you go back to 2003, there was some science that said that chloroquine worked against SARS-CoV-1, worked once again in vitro, that it was a potent inhibitor of its infection. And so there was plausibility that chloroquine and its cousin hydroxychloroquine could have been effective at treating coronavirus. And there's all sorts of biological reasons. I'm not going to get into all of the specifics as to what hydroxychloroquine does for viral infections. It works on the virus as an antiviral, but it's also an immunomodulator in a way, and works on our immune system. And so in a way, it may be a perfect drug for viral infections, in a way. And so people wanted to study this for obvious reasons. And this is Dr. Didier Farou, who's a French physician, who published one of the first case series. And to be clear, it's a open-label, non-randomized clinical trial documenting that his patients who received hydroxychloroquine cleared virus at a faster rate than his patients who had not received hydroxychloroquine. And so this, is, to be clear, is a non-randomized clinical trial, which I'm not entirely certain what that means, but it means, I guess, that he gave some patients, arguably, and hundreds of patients received it in these case series, hydroxychloroquine, and then compared them to a comparator group who did not receive it. Why each of these groups received the medication at hand is difficult to say. So based on that, the cat was out of the bag, so to speak. And I apologize for putting Donald Trump into your slides and into your worldview for a moment, but he was one of the main proponents of hydroxychloroquine being a useful treatment for coronavirus, pushing the FDA, pushing the message to a variety of different people that hydroxychloroquine should be the standard of care for all patients who are infected with coronavirus disease. This was followed up by a variety of different heads of state, Bolsonaro in Brazil, Modi in India, and a variety of others proclaiming the benefits of hydroxychloroquine. A part of that was its availability. It was a readily available, cheap drug, and so everyone could have access to it effectively right away. In many places in Brazil, they were handing it out at the testing sites for everybody who may or may not have been infected. And so I guess its availability drove a lot of this sort of messaging. And then after that, the FDA, the main regulator in the United States, issued an emergency use authorization for chloroquine and hydroxychloroquine for the treatment of coronavirus. And this is all ancient history at this point, back in March. But when we think about where we are now, it's important to think about what happened back then to see how we sort of could have done better and use data to inform this practice. And this is based on mostly that French paper, that open label, non-randomized case series of patients who received hydroxychloroquine, lowering the bar for what the FDA usually does to approve medications. Obviously, an emergency use authorization is not their typical bar, but still they require some high-quality safety and effectiveness data that this did not. And so if you look at prescription rates of hydroxychloroquine or chloroquine, this is CDC, so across the United States, you see that huge spike in March, and then you see it sort of rapidly decline in April and May. And we don't have comparative Canadian data, at least not at the system-wide level. But as we get into sort of the clinical trials approach, we were running various hydroxychloroquine trials, and a lot of physicians and a lot of patients did not feel comfortable participating in the clinical trial because there was a possibility that they would not be either giving their patients hydroxychloroquine or as a patient receive hydroxychloroquine. It had got to the point in March that this was the treatment for the disease, and convincing patients and convincing other physicians that we should be able to get randomized evidence was difficult. And that changed within a matter of weeks as the messaging changed. And obviously there's dubious data that's out there. This is one of my favorite studies, or I don't even want to classify it as a study, but it's on a website called hcqtrial.net, which effectively took all the countries in the world, clumped them into whether they received hydroxychloroquine or did not receive hydroxychloroquine, and effectively said that because patients or countries that had widespread early hydroxychloroquine use had lower mortality, since assignment is done without regard to individual information, assignment is random for the purposes of this study by country. And the treatment group has a 77% lower death rate with confounding factors affecting this estimate. I have not seen this published in a peer-reviewed paper, but this had gotten a lot of public attention and a lot of social media attention. Because when you see that bolded sentence going by you on your Facebook or Twitter or whatever your social media feeds are, it's hard to not appreciate the significance there. And so it behooves all of us to sort of be clear as to what we trust and what we do not trust. And so if you look at Google searches, obviously there was spikes along the way as different people proclaimed its effectiveness. This is worldwide trends, and you see spikes when Trump tweets about it. You see spikes when different people report different things. And then you see spikes again in July when Trump is again tweeting about it, asking that it should have a repeat EUA attached to it. We're not going to go into the details of some of the science that's attached to hydroxychloroquine, but I will mention that some of the just because something is peer-reviewed does not necessarily imply that it is something to be trusted as everyone has followed the Surgisphere debacle with likely fabricated data, which led to claims of harm of hydroxychloroquine that were not borne out by data. And so even though it may have satisfied your prior estimation as to what hydroxychloroquine was doing to patients, it was still unlikely to be true data, leading to lots of controversy about the publication of science and the peer review process. I will also say, sort of as a clinical researcher and someone who does clinical trials, I'll say this is a big problem in the sense that over the course of the first few months, there was hundreds and hundreds of clinical trials that were enrolling patients with hydroxychloroquine. And in most times, that's a good thing. We want more clinical trials, and we want more patients to be randomized so that we can learn. But on the other side, when all of these trials have target sample sizes of somewhere between 50 to 100, which is where their means and medians were, we knew that none of these trials would have informed practice by themselves. And they would all likely take a while to recruit and would all be underpowered. So I guess our inability to coordinate ourselves to answer a fundamental question, does this drug work, is something to be noted. This is sort of a clinical trial tracker that I check every now and then. So currently, there are 2,229 drug trials ongoing for patients with COVID-19. The vast majority of these will not hit their sample size or estimated sample size and will unlikely produce science that will inform practice. And notably, the bulk of these trials are being performed, as you would imagine, in Europe and North America, with lower income parts of the world, which are seeing the larger clusters of disease now, not being as reflected in the clinical trial enterprise. And so the number of trials obviously increased rapidly over the course of that first few weeks of the outbreak, with a likely primary completion date, many of them not until late next year, which doesn't necessarily inform this pandemic during this pandemic, which is the goal that we discussed at the beginning. And obviously, there's all sorts of different drugs being tested against each other. This is a network of all of the things being tested mostly against standard of care and very infrequently drugs against different drugs that we can get comparative data. So it's been sort of well documented that sort of COVID-19 drug research is a bit of a mess. And the lack of coordination amongst clinical researchers has led to sort of us knowing one thing and not much more than that. But I guess it speaks to some of the main challenges of doing research during a pandemic. Ethics of the control arm. Patients, as I mentioned earlier with hydroxychloroquine, wouldn't necessarily want to be randomized to something that was not the treatment that was available to them. Trials could possibly stop as other trials emerge, have data emerge, and lead to a loss of equipoise or a rapidly changing landscape of what equipoise is. Obviously, a time required to set up a trial with multi-site and ideally multi-nation coordination is the goal. And so that time takes a significant amount of time and requires a significant amount of coordination and collaboration. Having research staff present in hospitals available to consent and randomize is often difficult, particularly with surging patient numbers and PPE scarcity. And what we care about in the end is a mortality difference. We care about what makes patients not die. And for that, like anything, we need large numbers. While there's a reasonably high mortality rate of hospitalized and critically unwell patients, we still need large numbers to prove that a difference is present across multiple populations. And you want your drug to be relevant for all settings. One of the biggest challenges is this concept of, I guess, recognition. And as many clinical researchers have wanted to set up their own clinical trials and protocols, it's difficult to avoid the the framework of academic advancement and publications and so on that still exists and still drives a lot of the agendas. And to avoid that is something that's hard to overcome. And so it's easier to do a local study with one ethics application, one sponsor, one regulator, no contracts, than a global or a regional study, which takes quite a bit more time. Superimposed below that, that's the Public Health Agency of Canada's curve for case counts in Canada. I think it was probably cut off a couple of days ago or weeks ago, so you haven't seen that recent surge. But you see how as time quickly moves, it's difficult to scale up things like we want. And so Dr. Tedros, who at the WHO is clued into this idea that multiple small trials with different methodologies may not give us the clear and strong evidence we need about which treatments help to save lives. And so he has pushed a solidarity trial, which we'll talk about later on. This is the hydroxychloroquine data from that, plus the hydroxychloroquine data from the recovery trial, which is the large UK trial. And so large clinical trials to answer a question across a variety of different populations in a robust way, and proving that hydroxychloroquine is not effective at treating patients with coronavirus disease. This doesn't say anything about preventing disease from progressing or prophylaxing you from getting disease if you were exposed, but for hospitalized patients to prevent mortality, there is no benefit and arguably harm attached to hydroxychloroquine. Let's go to convalescent plasma, which is the next thing that's currently a reasonably hot topic. And so convalescent plasma has been around since literally forever, hundreds and hundreds of years. We've thought that convalescent plasma might work. This is a paper in JAMA about treating influenza pneumonia by the use of convalescent human serum. It's been tried in Ebola. There's a good randomized trial which showed no benefit for convalescent plasma in Ebola disease. Not a huge number of patients, but a trial nonetheless. Outside of that, there are really no good randomized evidence of the effect of convalescent plasma in an infectious disease. Despite its biological plausibility, you're providing passive immunity. It hasn't really been shown in any case series or any randomized trials to be effective. That being said, the FDA last week, or 2 weeks ago I guess now, issued an emergency use authorization for convalescent plasma as a potential promising COVID-19 treatment, an achievement in the administration's fight against the pandemic. And they made this claim based on this statement from the FDA commissioner that a 35% improvement is a pretty substantial clinical benefit, and that's true. What that means, and if the data continue to pan out, 100 people who are sick, 35 of them would be saved. And this was not necessarily true and was not borne out by the data that they used to approve it. What that 35% meant was a relative risk reduction between low and high titer convalescent plasma. So remember, convalescent plasma is antibodies, and you look at the titer of antibodies in a dose of convalescent plasma, and they show that the high titer had a 35% relative reduction in mortality compared to the low titer in an observational case series. So it's not obviously randomized evidence, and it's not even 35% improvement in survival or 35 patients getting better from 100. And so it's a gross misreading of the data. He's since walked that back and apologized for that statement, but nevertheless, it's still approved. I want to go to the study of the actual study, the 35,000 patients who received convalescent plasma in the United States, and they justify their approach with sort of a list of reasons as to why they couldn't generate randomized evidence for convalescent plasma. The first justification is that they needed a stable supply of product pre-positioned at all participating sites. And that's not necessarily true. You can have it shipped out in sort of sequence depending on where and when it's available, and if it's available, you can have a patient be randomized. Second, you need sufficient numbers of sites which have an appropriate patient base to approach for the study. I think in the United States, they've had that, namely numbers of patients and numbers of sites. And so it's not necessarily a problem for lack of available or eligible patients. Third, sites must be validated and activated. This work requires lots of sort of labor, and the crises of the COVID-19 pandemic were not compatible with this. I think this speaks to sort of a self-inflicted problem whereby we sort of collectively in the clinical research world have made our clinical research too cumbersome and too burdensome, where we need a great deal of on-site monitoring, where we need a great deal of paperwork, where we need a great deal of data collected for each individual administration, which leads to these complaints, which limits the amount of randomized data that we can possibly generate. Fourth, you need subject willingness. And obviously when various leaders are tweeting about the experience with coronavirus and convalescent plasma, this becomes difficult, and equipoise is rapidly changing. Fifth, once again, distrustful of a placebo based on historical precedent. I think, once again, this speaks to how we message what works and what doesn't work as a medical community. And then sixth, the number of sites who could have participated, who was the appropriate ethical entity to pick those sites, and why those sites and not other sites. So once again, speaks to the labor involved that we have set up for clinical trials, and we need to make sure that it is as available and equitable in terms of its accessibility as any other types of medical intervention. And finally, there's already small RCTs. People can choose whether to get the drug or participate in an RCT. And obviously that involves a great deal of complexity when you think about the patient having to consent to whether they want to be participating into a randomized trial or just get the drug, or convalescent plasma in this case. And when it's available and readily available and the clinician offers it, it becomes difficult to achieve informed consent in a thoughtful way. In Canada, we're lucky enough to have 2 randomized trials that are ongoing, and the only way of getting convalescent plasma is through these randomized trials. And so hopefully we'll be able to generate science in Canada to inform this practice. Remdesivir, looking at my clock, we have lots of time. Good, okay. Remdesivir, the next one that we'll talk about. This is a drug that's also been floating around for a number of years. It was clinical trials for Ebola and showed that it was not significantly useful in that context. But it has been authorized for patients in Canada for the treatment of patients with severe COVID-19. In the United States, it's been approved for both moderate and severe coronavirus disease, so any hospitalized. And so the Health Canada statement is notable. It's a sort of a provisional approval, so to speak, given the high unmet medical need, namely a lack of other therapies, and emergency context of the pandemic. Health Canada considered this balance of benefit and harm and considered it for Veklury, which is the trade name, to be positive. And so they gave an approval based on the data that was available. That data is, I guess, threefold or fourfold. There was a compassionate use series of remdesivir in the early phase of the outbreak that was published in April, showing across a case series a proportion of patients improved. And this was published back in April, which started to sort of gain attention for remdesivir as to sort of whether or not it could be the drug that we're all looking for coronavirus treatment. The Chinese randomized trial, and the Chinese need to be commended for setting up these randomized trials in such a quick time frame and publishing them and making them available to the world within just 2 months of patients arriving there. And this showed no benefit of remdesivir compared to control on a primary outcome of improvement rates. The NIH then also was running a clinical trial, and this was a press release that was announced in late April showing remdesivir accelerated recovery from patients with advanced coronavirus disease. Tony Fauci and all of the other American leadership proclaimed remdesivir to be the new standard of care based on the science that was available. And this was the ultimate paper that was published in New England a couple of weeks after that, showing of remdesivir compared to placebo, a significantly improved time to recovery outcome in the remdesivir arm compared to the placebo arm. There was no significant difference for the secondary outcome of mortality, and for the severely unwell, there did not seem to be a benefit. And so if any benefit, it's present in the patients receiving oxygen but hospitalized, but not in the more severely unwell. They also published another study more recently. This is a week or 2 weeks ago now, looking at more moderate disease. And this didn't really show a significant benefit on an ordinal scale, although maybe the 5-day course was better than the 0-day course. But the 10-day course was worse than the 5-day course and worse than the 0-day course. So it's sort of confusing as to how to interpret this. One thing of note is that this was an open label study, and you see how these hospital discharges were to spike on the day after their course was finished. And so in many ways, clinicians were keeping patients in hospital longer to complete their course of provided remdesivir. And so that's notable as a public health or sort of a health system perspective as to how we're sort of managing our allocation of drug, but also how we administer it to patients who may be improving, and we want to clean up the health system to make sure that there's space for more patients during a time of surge. Obviously, the elephant in the room is cost. I don't like bringing it up too often, but the U.S. has spent about a couple of $2 billion on their stockpile of remdesivir. Canada, the cost is likely to be somewhere between $4,000 to $5,000 Canadian dollars per course. And so something to be aware of as we sort of scale up availability of this drug. The second elephant in the room, and I photoshopped that in myself, is availability. It's a relatively inaccessible drug as they scale up production, and particularly with most of the world seeing larger outbreaks with more deaths, namely Latin America and Asia. Ensuring accessibility of this product to the world is something that we all need to work on. I always like to keep track of Gilead stock prices to see how the world is sort of reacting to remdesivir, because it goes in waves, as you've seen. And you saw that spike in May when they released that paper, and it's been trending downward since then as sort of enthusiasm waxes and wanes accordingly. More data will be forthcoming on remdesivir from a randomized perspective in the coming weeks. Steroids. The last sort of main drug we'll talk about briefly, and steroids have been around forever. As you know, we know that for influenza, there's randomized evidence that says maybe it's harmful. We know that for community-acquired pneumonia, we say we have randomized evidence, but very small studies that say maybe there's benefit in the severe context. We see that for ARDS, or acute respiratory distress syndrome. We see maybe a benefit across studies with heterogeneity attached to them. And so there hasn't really been a good set of data to say steroids need to be given to any specific group of patients. At the beginning of this outbreak, colleagues wrote that corticosteroid treatment should not be used for treatment of disease outside of a clinical trial, and thankfully clinical trials have happened. And this is kudos to our UK colleagues who were able to randomize 10,000 patients in a very quick time frame. And 6,000 of them were to a steroid or usual care arm, showing fairly clearly that patients who were severely unwell requiring oxygen, or those who were ventilated, survived more. And that was sort of a striking finding. This is a 30% or 20% drop in mortality, which is something that we almost never see for any clinical trial. And so there was a small cadre of individuals who always say, I've never changed my practice with just a single trial. In some ways, the recovery results were too good to be true. And so a few of us decided to accumulate evidence in a prospective way and get all of the other trials that were ongoing evaluating corticosteroids to see if that result was consistent. I'm going to skip over these sort of more science, more meta-analytic strategy approach, but sort of jump to a meta-analysis that came out last week showing across all of these trials there was significant benefit on mortality of steroids. And so 7 different trials were ongoing at the time. They all stopped when recovery reported their results. and then they all pooled their data in real time and then reported themselves independently, but also into a meta-analysis that directly informed guidelines that says that steroids should be given to severely and critically unwell patients with COVID-19. So that's a sort of exciting finding in that we are able now, compared to 6 months ago, reduce mortality of patients with coronavirus by a significant proportion, specifically patients who present to hospital. And that's really what it boils down to as we are all sort of staying home and waiting for this pandemic to finish, is we want this disease to be lessened in severity. And if we have things like steroids and hopefully other things, that could be a huge boon as we start to open up our societies. And this is a consistent effect across all of the pre-specified subgroups, which is obviously good news. And so all of these trials published independently at the same time, sort of a collaborative effort across researchers around the world so that we can inform things as fast as possible. So I'll point everybody to the BMJ, which is producing and maintaining a living guideline on drugs for coronavirus 19. And so as soon as any new randomized trial is released, it's populating into this guideline, and the guideline panel meets. There's a meta-analysis that's performed in real time, and the recommendation is provided. And so steroids get a strong recommendation at this point. And there's an active network meta-analysis comparing different drugs to each other. And so right now, for example, steroids trump all of the other available medications that could possibly work, which is only remdesivir at this point with randomized evidence behind it. So to speak to sort of the need for high-quality randomized evidence briefly, I think we've noticed over the past 6 months a huge amount of observational interventional data discrepancies. We saw hydroxychloroquine with observational data showing benefits, hydroxychloroquine with observational data showing harm. We have interventional data showing no benefits. We have convalescent plasma with observational data. We don't have any good interventional data or large-scale interventional data, although new studies are emerging that show no benefits. And we have observational data for steroids during this pandemic in the UK by the same investigators that show that steroids are associated with harm, and only in the interventional data sets do we see the benefits get revealed, speaking to the, I guess, the treatment effect of, or the bias of giving steroids to patients who are more sick than otherwise we would have. Also the idea that biologic plausibility does not equal clinical benefit, and the importance of actually doing the trial. Hydroxychloroquine is biologically plausible, but it does not equal actually having benefit. And then the importance of sort of avoiding the concept of small trials underpowered for the important patient outcomes. What we care about mostly is mortality, but there are other important patient-centered outcomes. And as those early trials get reported, leading to overuse in the absence of definitive data. So what we know right now, we know steroids are good. We know hydroxychloroquine for hospitalized patients is not good. But we need to know more about convalescent plasma. We need to know more about remdesivir. We would like to know, does anything else work? Is there anything else out there? And also, I've been focusing on hospitalized patients. What we'd like to know is whether there's anything for outpatients. As soon as you get a diagnosis, can we get anything that prevents you from becoming hospitalized or becoming critically unwell? And that's a major gap that people are working on and actively working on. There's obviously lots of trials ongoing, some of them looking at those things, a lot of them overlapping, and a lot of them looking at the same thing. I'm watching very closely in terms of what's coming up in the next few weeks to months. The monoclonal antibodies, there's a lot of work happening on those. Anticoagulation, large-scale randomized trials are being performed right now. Some new targeted immunomodulators, once again biologically plausible, but I'll wait to see whether or not they have clinical effects. And some new antivirals in that outpatient space, see if you can prevent hospitalizations or severely unwell patients. And so this data will start to emerge at sort of small scale in the next few weeks to months, and then hopefully scaled out to larger scale studies for definitive evidence afterward. Okay, briefly, I want to talk about in the last 5 minutes or so how we sort of change it so that we can learn faster. Back to this figure, we want to push that curve leftward. We want to learn as much as possible, as quickly as possible. This is a New York Times article saying these clinical trials of drugs are taking longer than expected, specifically the monoclonal studies. because they don't have the ability to test patients to prove that they're positive. Hospitals are too busy. Patients don't want to be randomized, and typical things as we spoke of. And so there's a great editorial that a colleague of mine wrote about sort of the trade-off between learning and doing in a pandemic. And the three major problems are, one, it's uncomfortable as a clinician to randomize your patients. You don't know what's right. As those early sort of papers from China reported, it's difficult to know what to do. Randomization is deeply uncomfortable. We know that RCTs are too cumbersome. There's a lot of paperwork. There's a lot of work to be done to get it up and running and get it sort of collaborative and available to everyone around. And a unified plan among researchers, among funders about what to do and how to answer a question in a coordinated way for everybody. Some solutions. We need to make randomization more comfortable and more embedded within care. And that's been done through a variety of different ways. Namely, we can say change the allocation strategy. So it's not 50-50, it's more like 75-25 or something like that. So patients are more comfortable being randomized and physicians are more comfortable randomizing. Make RCTs simpler. The recovery study in the UK was great in that it collected just basically one page of data at presentation and then one page of data at outcomes. And that outcome data was collected from their health system through their national administration database at the NHS. There's no way we have that capabilities in Canada, both from a regulatory perspective of the need for safety data and then from a outcome assessment data from a collaborative and coordinated data infrastructure in Canada, which is lacking. The sacred cows of research, namely placebos and blinding and all these things that we talk about greatly as we think about risk of bias, those are often perfect being the enemy of good. We want just randomization and evidence to inform practice. We want to cast a big tent. We want to ask as many questions as possible. We want to sort of engage the world as much as possible. The clinical systems. We want to embed research into care. There's some cool trials happening where within, say, the electronic health record, as you're seeing a patient, you're typing in their notes, it prompts you that you should randomize this patient, and within your orders in a hospitalized patient, a random allocation is provided if they get consent. It's all embedded within care. Equipoise. Equipoise is a tricky concept, and I think really embracing the concept of equipoise within clinical practice is important. Right now, we think that we know a lot of things as we provide care to patients. Much of those are not, say, driven by good quality evidence, and sort of engaging our patients in the context of we don't know a lot about the things that we do, and we want to learn more instead of presuming that what we do is the right way. And obviously engaging patients in these discussions, the consent concept, embedding research into care, and sort of defining that concept of equipoise. We wrote in a couple of weeks ago about how Canada can better do this. I think there are some major challenges in the Canadian context that are specific to Canada. Things like infrastructure, about how we sort of share data across institutions. There's a lot of interinstitutional politics and logistics about data sharing and financial sharing, which does not need to be there from a coordinated health system. Clinical research should be sort of prioritized across the country as to sort of answer questions in sequence rather than in parallel so that we can get answers quickly. The regulatory requirements for data collection is often a cumbersome issue and decreases the ability to randomize. And then integrate all of our other data collection and sharing infrastructure that exists already into clinical research. So to conclude, we need to sort of to build this learning health system so that we can incorporate this stuff into healthcare and specifically into pandemics will require an unprecedented amount of coordination amongst clinicians, researchers, policymakers, politicians, the public. So it's less a scientific problem and more a political one. But I think this is the opportunity that we need to take to sort of reflect on what we think about when we say we want to learn as we provide healthcare. And I think we can all sort of learn from this pandemic and see it as an opportunity. I always reference this Arundhati Roy. She's an author from India. She wrote a great essay a couple of months ago about how this pandemic, she wasn't referring to clinical research or clinical trials, of course, but sort of the world that we can build afterwards. I'll let everyone read this on their own right now. But I guess it takes all of us to sort of think about what we want going forward as to what we think the world should be like, and specifically the world of clinical research and clinical trials and the care we provide our patients. And we want to make sure that we want to build that system, and this is the opportunity to fight for that new system. So I'll stop there with, I guess, a conclusion. Or randomization is fundamental to learning, especially in clinical practice. We have learned a lot about COVID-19 over these past 6 months, but not nearly enough. I see the chat populating. I'm going to stop sharing my screen there because that's all the slides I have. How should I frame this? So how would I go to the questions?
Well, Srin, it's Aaron. I've made a note of the questions, so to save you the trouble, I can just read through them. Before I do, I just wanted to say thank you. It was very, very interesting presentation. You're very well spoken and a lot of food for thought. So if you don't mind, we'll get right into it. The first comment I'll read is, I've attended a zillion Zoom talks. This one was one of the best. So congratulations on that. So the first question, do you have any comments about oral prednisone? And if so, if you think it's an option, would you consider giving it to outpatients?
Yeah, we don't really have data that says it's either safe or effective in outpatients. All we have is data on dexamethasone and now hydrocortisone on hospitalized patients, and specifically hospitalized patients who require oxygen, so more severely or critically unwell. And so the current science says that we shouldn't be giving steroids to the outpatient or even the mildly unwell who will require hospitalization. In the recovery, the UK study, there may have been a signal towards harm if given in that sort of very well population. So it's important that we tailor the medicines to the right population to make sure we see its benefit and also avoiding its harm.
Okay, thank you. The next question, for outpatients, do you have any comments on vitamin D, vitamin C, zinc, ASA, vitamin K2?
No, of course. I think many of those things are actively being studied right now, and there's a lot of good vitamin D studies actively. There's a few zinc studies that are actively ongoing. There's aspirin studies that are definitely ongoing. As I talked about earlier, there's anticoagulation ideas about coronavirus being a pro-thrombotic disease. And so heparin, aspirin, antiplatelet drugs of other kinds are all being thought about. So all these things require good study. I wouldn't empirically yet, in the absence of that, start any of those medications on outpatients with it. So right now, with outpatients who present to your clinic or hospital with a mild disease, unfortunately, there's not much that we can give yet to prevent them from getting worse. And that's sort of what we're looking for, and the monoclonal studies are looking at that specifically, and there's a bunch of other, say, early antiviral studies that are looking at that also. And so I think that's a major sort of space that needs to be filled, while I'm focusing mostly on the hospitalized cohort, because that's where the most of the studies have been done thus far. We're starting to think about ways that we can sort of design studies and which medications to use in the walking well, so to speak, with positive disease.
Okay, great. I'll just pause for a minute, give you a chance to catch your breath, and remind the audience that of two things. One, again, if you want the continuing education credits, please make sure that you watch your email for the evaluation form, complete it, and send it back via email, and then be patient. We will for sure send you your continuing education credit certificate electronically. And the other thing to note is that the presentation tonight, the video recording, will be posted on our website within a few days. So if you want to refresh yourself about what was discussed or pass this on to someone that wasn't able to attend, you could refer them to the link. So keep an eye out on the TI website for that, and we'll probably mention it on our Twitter account that it's been posted. Okay, Srin, the next question I have is maybe slightly off topic, but there's conflicting reports about the length of immunity after being infected. There's one report of greater than 4 months, but that hasn't been corroborated. Do you have any comments about that?
Yeah, no, I think that's a fundamental question as we start to sort of move into this next phase where we have a lot of survivors and we're able to learn a lot about them in terms of A, their chance of reinfection, B, the likelihood of a vaccine having long-term effectiveness, and all of the other factors that go with immunity. And so we think that these antibodies persist. We have seen isolated cases of reinfection, but they've been mild and well controlled by healthy immune systems. And so I'm not particularly worried yet, knock on wood, that waning immunity, at least in the short term, is a major problem. But we will see how the data emerges over the coming weeks and months.
Okay, great. Thank you. I have a question for you. Say I was a patient or I was a clinician and I had someone that would be interested in being enrolled in a randomized controlled trial. Where would a local clinician find out the best way, is there a trial that their patient might fit into?
Yeah, and so like in British Columbia, there's a variety of sort of resources for that exact concept. And so I'll give a plug for Clinical Trials BC, which has an active history of what's available here in the province and what's active and where it is. And so their website is updated fairly regularly. And so clinicians can check on that. And there's a few outpatient trials that are ongoing. And so people can sort of refer them to that. I think the concept of getting randomized evidence as much as possible is so important right now as we sort of want to minimize the burden of this pandemic on the larger system. We can't do that without learning what works and what doesn't work. I mean, the only way we can do that is, as I talked about, is through these types of studies.
Okay, great.
I see Larry there. Hi, Larry. Talking about Reach, which is a great platform for recruitment, and Aaron, you posted the website, which is great.
Yeah, thanks, Larry. That's all the questions that are in the chat. I'm wondering if, Tom, do you have any questions you have for Srin?
I just want to echo Karen Palmer, who commented that this was such a good presentation. I thought it was brilliant, Srin, and you managed to stay in time, which is miraculous. And I think we want to invite you back in about a year, or depending on the pace of events, 6 months to a year, not only to talk about results, but to talk about whether Canada has learned, or any other country has learned anything about changing the model of research. The quotation from Arundhati Roy made me decide I got to join my wife, who's read many of her books. I'm going to have to start digging them out. But I just want to thank you again. I thought that was a wonderful presentation. And I don't often say that.
Srin, it's Aaron. I'd offer you the last word before we call the evening to a close.
No, thank you, everyone, for listening to me for the past hour. It's always fun to share these ideas with people. Have a good night.